Hi, I'm Dr. Adel Angelo, Pharmacology Department. I'm going to give you a lecture on Infection 2, Part 1. This is drugs used in chemotherapy of tuberculosis or treatment of tuberculosis. Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis. In the past, this disease used to be with a fatal outcome. But now, thanks to the discovery of so many anti-tuberculous drugs, it is considered as a disease with a nearly curable, 100% curable cases. But still, we have some problems in treatment of tuberculosis. First, the infection in TB tends to be exceedingly chronic. It means chronicity of the condition. Secondly, organisms are frequently intracellular inside the macrophages. This means that our organisms are inside the cells. We have to use drugs to invade the cells, to penetrate cells to reach these microorganisms. Drugs with poor cell penetration cannot be effective in treatment of tuberculosis. Thirdly, the mycobacteria are slowly growing or sometimes are non-growing, and the organism can be also dormant. This means that the metabolism of the organism is very slow, and the organism may be slowly metabolizing or non-metabolizing. And in such a case, it's difficult for some drugs to attack this organism and causes drug resistance. Thirdly, or fourthly, bacteria tend to develop resistance against drugs. So in case we use one drug against TB, liability of resistance is high. Hence, it is recommended that no monotherapy treatment for tuberculosis, but multiple drugs must be used, or combination of drugs must be used in treatment of tuberculosis. Also, treatment must be administered for months to years. In the average, it is 6 months, but maybe up to 2 years. This means that we have to know everything about the drugs given, the pharmacology, the pharmacokinetics, the adverse effects, the mechanism, the interaction of drugs. All of these have to be studied, particularly for the anti-tuberculosis drugs. So, as I mentioned, we have now many drugs to be used in treatment of tuberculosis. And whenever we have many drugs, we have to classify such drugs. So, the classification of anti-tuberculosis drugs is based on the efficacy of the drugs and on the toxicity of the drugs. They are being classified into first-line agents characterized by greatest level of efficacy and acceptable degree of toxicity. This includes 4 drugs. We call them the 4 drugs, or the 4 essential drugs for treatment of tuberculosis. These drugs include isoniazid, rifampin, pyrazinamide, and ethambutol. These drugs can be used in treatment of a large number of cases of freshly recognized tuberculosis. Second-line drugs, these are more in number, but these drugs are less effective and are more toxic. Hence, these drugs are used in case of resistant to TB or resistant organism, also in cases of patients' intolerance to the first drugs. Now, let's start by the first drugs, or what we call the essential drug. These are 4 drugs. For each drug, we are going to study its antimicrobial activity, its pharmacokinetics, its mechanism of action, and adverse effects. First of the anti-tuberculosis drugs, first of the first-line drugs, is isoniazid. This is a chemotherapeutic agent. This isoniazid has its antimicrobial effect limited to tuberculosis. It has no other antimicrobial action. And this drug acts particularly on rapidly growing bacilli, and it penetrates cells with ease and is able to act on intracellular bacteria. Hence, we say that isoniazid is effective against rapid multipliers. Regarding the kinetics or pharmacokinetics of isoniazid, this drug can be given orally. It is well absorbed after oral administration. It diffuses into all body fluids and tissues and crosses the blood-brain barrier, reaches the CSF. This means that this isoniazid can be used in treatment of tuberculous meningitis. Also, it rapidly diffuses inside the cells, but intracellular and extracellular levels are the same. This is very important because, as we mentioned, the organism, mycobacteria, is inside the cell, and we need an agent to penetrate freely. Free penetration gives an advantage to the drug. This is the advantage of isoniazid. Isoniazid is metabolized in the liver through N-acetylation and hydrolysis, resulting in inactive products. As regards the mechanism of action, isoniazid is a prodrug, and it is not active as such. It is activated by an enzyme called catalase peroxidase. This enzyme is provided by mycobacteria, and this enzyme converts isoniazid to the active form. The active form of isoniazid inhibits synthesis of mycolic acids. These mycolic acids are among the essential components of mycobacterial cell wall. Hence, this isoniazid through this mechanism leads to bacterial cell death, and thus isoniazid is a bactericidal agent. If we look to the therapeutic uses of isoniazid, isoniazid is used successfully in treatment of tuberculosis, but never alone. Never monotherapy, because resistance will develop rapidly. Hence, combination of drugs should be used, and this will be mentioned later. And also, isoniazid can be used in chemoprophylaxis. Chemoprophylaxis, it is the condition in which it is allowed to use monotherapy, one drug. Isoniazid can be used alone in chemoprophylaxis in conditions such as close contacts of freshly recognized cases of TB to give a sort of prophylaxis. This can be used as monotherapy. Regarding the adverse effects of isoniazid, collectively we can say that these adverse effects are summarized or collectively on the CNS and liver. Regarding the liver, it might cause liver injury. This is not common, and the drug is well tolerated, and this may be just elevation of transaminases, but sometimes in rare cases may be severe hepatitis with a fatal outcome. This drug, liver injury, may occur particularly if there is a pre-existing liver disease, or in case of elderly people, or in case of alcoholics. Those are more liable to develop liver injury. In such a case, it's preferable to monitor liver enzymes. The other adverse effects we have peripheral neuropathy because it interferes with pyridoxine metabolism. Isoniazid has a chemical similarity to pyridoxine. Pyridoxine is vitamin B6, and this results in interference with the formation of the active form of pyridoxine, leading to increased pyridoxine excretion in urine and deficiency in pyridoxine, leading to a sort of neuropathy as manifested in the patient by numbness and tingling in the feet. And this can be corrected by administration of pyridoxine, as will be mentioned later. Hypersensitivity reactions may also occur. Convulsions may occur in epileptic patients, particularly that isoniazid leads to inhibition of some anti-epileptic drugs. Mental disturbances and ataxia may occur not common with isoniazid. And hemolysis may occur in case of glucose 6-phosphate dehydrogenase deficiency. This is a condition that is provoked by so many drugs. There is a list of drugs that can provoke this hemolysis. Among this list is the isoniazid. Also, systemic lupus erythematosus-like syndrome may occur with isoniazid. Now, we come to the second drug of the essential ones, the 4 essential drugs. This is rifampin. Rifampin is a chemotherapeutic agent. I mean, it is an it is a broad-spectrum antibiotic. It is an antibiotic which has its effect not limited to Mycobacterium tuberculosis, but also it acts on Mycobacterium leprae, and also it acts on some gram-positive microorganisms as Staph aureus and some gram-negative microorganisms such as E. coli, Neisseria meningitidis, Haemophilus influenzae. All of these are affected by rifampin. But we are concerned here about its effect on Mycobacterium tuberculosis. This drug has its activity against rapidly dividing and semi-dormant bacteria. These effects account for its sterilizing activity, and it is particularly affected. It affects the intermittent multipliers or the persistent. This is very important for rifampin, hence it is used for a long time to prevent the occurrence of relapse. Regarding the pharmacokinetics of rifampin, rifampin is a drug that can be given orally, and it is well absorbed after oral administration, and it is partly metabolized in the liver. However, these metabolites are still active, and the metabolites of rifampin are excreted in the bile. From the bile, it goes into the duodenum, and then it is reabsorbed. This forms a sort of an enterohepatic circulation for the drug, which prolongs its action. Finally, it is excreted in the bile, and the feces is the main source of excretion of the drug. Rifampin is a drug metabolizing enzyme inducer, particularly on cytochrome P450 inducer, and decreases its own metabolism as well as the metabolism of some other drugs. This will be mentioned later with some details. It crosses cell membranes and so can attack intracellular bacteria and bacilli. This is very important. As I mentioned, mycobacilli or Mycobacterium tuberculosis are present inside the cells, mainly, particularly in the macrophages. Hence, penetration of the cells is very important for the efficacy of the drug. It reaches CSF in effective concentrations. It crosses the blood-brain barrier. Hence, it is very useful in cases of tuberculous meningitis. Its metabolites of the rifampin may impart an orange-red color to all body secretions, all secretions, including the urine, the feces, the saliva, the sputum, the sweat, tears, and contact lenses. All of these will be tinged by an orange-red color. And the patient has to be warned about this. And also for you as a doctor, this orange color of the urine or the secretions is a sign of patient compliance. It means that the patient is taking the drug regularly. Regarding the mechanism of action of rifampin, rifampin inhibits the synthesis of RNA. With more details, it binds strongly to bacterial DNA-dependent RNA polymerase, and this results in inhibition of RNA synthesis in bacteria, but human RNA polymerase is not affected, and hence this results in a bactericidal effect of rifampin. Regarding the adverse effects of rifampin, we can say collectively they are on the liver and allergic and immunologic reactions. In INH, isoniazid, we said mainly on CNS, and liver. Here mainly allergic and immunologic and the liver. Regarding the liver, hepatotoxicity, this is not so common. The drug is well tolerated, and it may range from just elevation of transaminases up to severe hepatitis with fatal outcome, and this is not common, it's rare, but it occurs mostly if there is a pre-existing liver disease, mostly in alcoholic and in the elderly. In those vulnerable populations, it's possible, or it's better if we can monitor the liver enzymes. It's much better. Also, cutaneous reactions and hypersensitivity reactions may occur. Influenza-like syndrome or the flu-like syndrome occurs in 20% of patients and is associated with intermittent administration. This means that the flu syndrome, which is allergic in nature, it appears in the patient like a flu, by fever, chills, myalgia, flu. And if you stop the drug, everything goes back to normal. This is associated with intermittent administration of the drug. It is much less evident if the patient is taking the drug regularly. Intermittent administration may be due to patient taking the drug not on a regular manner, poor patient compliance, or if the patient is put on a system that allows administration in an intermittent manner. Thrombocytopenia is allergic in nature also because it is associated with the presence of circulating IgG and the IgM antibodies. Rifampin is a powerful inducer of hepatic cytochrome P450. This is a drug metabolizing enzyme and may lead to oral contraceptive failure. Of course, it affects the metabolism of so many drugs. But we will take just one example: oral contraceptive failures. If a woman is taking oral contraceptive failures and she has to take rifampin, she is liable to get oral contraceptive failure. Why? Because rifampin induces cytochrome P450, drug metabolizing enzyme, accelerates the metabolism of the oral contraceptives, their serum level decreases, and we are liable to be faced with oral contraceptive failure. The third drug of the essential drugs is ethambutol. It is a chemotherapeutic agent. Ethambutol by itself, it is not a strong drug. And you might ask, why it is included in the first line agents or is essential while it is not strong? Because it has some beneficial effects. This beneficial effect lies in the fact that if you combine ethambutol with iron H and rifampin, it decreases the emergence of initial resistance to these two drugs. Very important. Our aim in TB is to minimize the development of resistance. So it is put in the combinations to minimize the development of resistance. And this ethambutol is a bacteriostatic drug. Regarding the kinetics of ethambutol, over 75% of the drug is absorbed after oral administration, and it enters most body tissues, and insignificant amounts of ethambutol crosses the CSF if the meninges are not inflamed. But in case of tuberculous meningitis, when the meninges are inflamed and we get hyperemia, it crosses the blood-brain barrier and can be used in combinations for treatment of tuberculous meningitis. Also, it is eliminated unchanged in urine, and it needs dose adjustment in case of renal impairment. Regarding the mechanism of action of ethambutol, this drug also acts on mycobacterial cell wall. INH, the previous drug, isoniazid, acted on mycolic acids, but here it acts on another component of mycobacterial cell wall. This is arabinoglycan. Arabinoglycan is an essential component of mycobacterial cell wall, and this leads to its bacteriostatic effect. The adverse effects of ethambutol, the most important adverse effect of ethambutol is optic neuritis. Fortunately enough, this is not common. It's around the range of 1%. But it is so serious because first it is in the form of visual disturbances, visual inaccuracy, and red-green color indiscrimination. And in such cases, if the patient continues taking the drug, it might lead to blindness. But if we stop the drug administration, reversal of these changes occur. Hence, it is very important for the patient taking ethambutol that in each monthly visit in the clinic, we ask him about any visual disturbances, any color indiscrimination, or any visual field defect. We ask the patient. In such cases, we have to stop drug administration. And also, we have it's better if the patient is vulnerable to optic neuritis that we measure the visual acuity and color discrimination before starting treatment. But this is not usually needed. Regarding the administration of ethambutol to children, it is not contraindicated, but it is not recommended that we give ethambutol to children below 13 years of age. Why? Because this child, if he comes to you and says that he has some visual disturbance, he cannot see properly the blackboard or the teacher, and you are not sure if this child is taking ethambutol, you are not sure if this problem is an actual visual problem which need correction, or it is due to ethambutol. Hence, it interferes with these visual tests in such a young age. Also, peripheral neuritis may occur with ethambutol. The fourth drug in the essential drugs for treatment of tuberculosis is pyrazinamide. Pyrazinamide made a revolution in the treatment of tuberculosis. Before introduction of pyrazinamide, treatment of tuberculosis used to be for 9 months to 1 year minimum. But after introduction of pyrazinamide, the duration of therapy, the short course, became only 6 months. So it is very important drug in treatment of tuberculosis. This is because this drug acts on the slow multipliers. Those slow multipliers, which may be the dormants, which metabolize slowly or do not metabolize at all, and these dormant microorganisms may cause relapses later on. But the use of pyrazinamide eradicates these organisms and hence decreases the relapse rate and is effective in treating cases of tuberculosis. Regarding the pharmacokinetics of pyrazinamide, pyrazinamide is a drug that can be given orally. It is well absorbed from the gastrointestinal tract after oral administration. It is widely distributed throughout the body and the CSF. Hence, it can be used in treatment of tuberculous meningitis. It is partly metabolized in the liver. Hence, it is liable to cause liver injury. And the parent drug and the metabolites are excreted in urine. Pyrazinamide, like isoniazid, is not active as such. It is a prodrug that has to be activated first to act. This activation occurs through an enzyme called pyrazinamidase. This enzyme is provided by microbacteria that activates pyrazinamide into pyrazinoic acid. This pyrazinoic acid lowers the intracellular pH to an extent that it interferes with the vital enzymes in fatty acid synthesis in microbacteria. Hence, synthesis of fatty acids in microbacteria is going to be disturbed, leading to death of microbacteria and hence its bactericidal effect. Regarding the adverse effects of pyrazinamide, first is liver injury, and like the other drugs, it's not common and might be mild, might be with fatal outcome, but this is rare, and it is more liable whenever there is a pre-existing liver disease, whenever they were giving the drug to elderly people or to the alcohol. Also, there is non-gouty polyarthralgia, and this pain can be treated with non-steroidal anti-inflammatory drugs. Also, asymptomatic hyperuricemia may occur with pyrazinamide. This asymptomatic hyperuricemia is due to the fact that pyrazinamide is converted to pyrazinoic acid. This pyrazinoic acid interferes with the urinary excretion of uric acid, leading to elevation of uric acid level in the blood. Acute gouty arthritis is not common, but may occur if there is a pre-existing gout in the patient. So let's collect the advantages of the use of pyrazinamide in treatment of tuberculosis. First, it kills the slow multipliers and the semidermal. This is very important. Secondly, it is bactericidal in the acidic medium inside the macrophages. Don't forget that pyrazinoic acid generates acidity. Resistance is not easy to develop. I don't say there is no resistance to pyrazinamide, but it is not easy to develop like other drugs. So it is a good drug with relatively low incidence of resistance. It has a potent sterilizing effect against residual intracellular organisms. Also, it decreases the relapse rate. A very important point for pyrazinamide is that it is highly effective during the first 2 months of treatment while acute inflammatory changes are present. This means that pyrazinamide exerts all of its effects on the slowly metabolizing slow multipliers in the first 2 months. So we give pyrazinamide for only 2 months. We don't need to give it any more than 2 months. This is an important point, don't forget. Also, its use shortened the duration of therapy to 6 months. Now, you have the 4 essential drugs for treatment of tuberculosis, and you have patients suffering from tuberculosis. How can you treat a case of TB? How can you use these drugs? To use these drugs, there are certain principles or guidelines that we have to follow. Treatment should be initiated promptly, even before results. Whenever you diagnose tuberculosis by acid phosphocellulose or X-ray, start treatment. Don't wait for any other investigations. And the most effective strategy to ensure adherence to treatment is the DOT strategy. DOT is directly observed treatment. This is the DOT, directly observed treatment. So what is DOT? DOT, the patient meets the health worker every day for several times a week. Every day. He is not allowed to take the drug by himself. The health worker gives the drug for the patient every day. And the patient takes TB medicine while the health worker watches him. Hence, the word is observed. It is observed, directly observed. And the health care worker also asks the patient about any problems or side effects with the medication. This is very important to detect any adverse effects early and to manage with these adverse effects. Also, the DOT should be used for all patients with TB. All patients should be treated by the DOT strategy. So, what are the advantages of the DOT? First, we can get rapid cure by elimination of both rapid and slow multipliers from the patient's body. Secondly, low failure rate. Thirdly, reduction of emerging drug-resistant strains. And fourthly, improved patient compliance. These are the advantages of the DOT. But what is the difference between DOT and DOTS? DOT means giving the drug under medical observation. This is DOT. Any tuberculosis patient suffering from TB should be treated by DOT. We mean he should receive his drugs under medical supervision. So what is the DOTS if we add S This S is for the term short term, 6 months. This is a special type of dot in which there is limitation of the duration to 6 months. So dot is a broad terminology, not limited by time, and the dots is a term of dot limited by time, 6 months. This is dots. Let's know the details of dots. Okay, the dots consist of an intensive phase of 2 months of isoniazid, rifampin, pyrazinamide, and ethambutol. That is the 4 essential drugs. You give the whole 4 essential drugs once daily, followed by a continuation phase of 4 months of iron H and rifampin. During the initial phase, which is 2 months, giving 4 drugs, the majority of tubercle bacilli are killed. The symptoms resolve, and the patient usually becomes non-infectious. In the continuation phase, which are the next 4 months, in the first 4 months we give 4 drugs. The most important here is pyrazinamide, which is to be given for only 2 months, and we stop. Then the next 4 months we give only 2 drugs, iron H and rifampin. The continuation phase is required to eliminate the semi-dormants or the resistance, and all included drugs are given once daily during the course. This will clarify how treatment of tuberculosis should be done. In few words, should be done under medical supervision. This is dot, and if the patient is suitable for applying the essential drugs, so we use the dots, the short course multiple drug therapy. This is the dots. Also, in treating tuberculosis, we have to notice that pyridoxine, which is vitamin B6, is given with iron H to all persons at risk of neuropathy. We know that isoniazid and pyridoxine, there is a sort of chemical similarity between them, and this results in that pyridoxine metabolism or formation is interfered with by isoniazid, and pyridoxine output in urine increases, and the patient is liable to get pyridoxine deficiency or vitamin B6 deficiency, and in such a case he is going to suffer from peripheral neuritis, numbness, and tingling sensation in the fingers. In such a case we have to give the patients who are at the risk of neuropathy. Those are the pregnant women, the breastfeeding infants, the patients with renal disease, patients with malnutrition, patients with HIV virus. All of such conditions are vulnerable cases, and we have to give pyridoxine by a dose of 10 milligram pyridoxine to each 100 milligram of isoniazid. This dose leads to disappearance of the peripheral neuropathy, and it does not interfere with the activity of isoniazid. Now, we finish with the first line drugs. These are the most important drugs in treatment of TB. These are the drugs for you as a student. You have to know all details of such drugs, regarding every details of the drug, as I mentioned, for the first line drugs. And most of cases of tuberculosis, drug susceptible cases, are treated by first line drugs. But sometimes we cannot treat patients with first line drugs. Why? What are the indications for use of second line drugs if we cannot use the first line drugs? First, in case of drug-resistant tuberculosis, in case of drug resistance to first line, we have to move to second line. And in case of patients intolerant to the first line, patient may be not tolerant of the first line. For example, he may suffer from some adverse effects, optic neuritis, for example, with ethambutol, liver affection, or liver injury, may occur with pyrazinamide, with isoniazid, with rifampin, or gouty arthritis with pyrazinamide. And the patient may also suffer from hypersensitivity reactions and thrombocytopenia with rifampin, fluorouracil. In all such conditions, we have to stop the drugs and we have to manage and move to the second line drugs. These second line drugs are usually less effective and are more toxic. They are not welcome, but we have to move to second line drugs. So these second line drugs may be given orally or may be given parenterally. The oral second line drugs include the belamimide, the bedaquiline, fluoroquinolones, moxifloxacin, levofloxacin, levofloxacin, thoramides, ethoronamide, prothionamide, cycloserine, para-aminosalicylic acid, linezolid, and clofazimine. These are some of the oral anti-tuberculous drugs, but there are some other drugs, but those are the most important ones. Regarding the injectable or the parenteral second line drugs, these include the second line injectable drugs. They are collectively referred as the aminoglycosides, the amikacin, kanamycin, and the cyclic polypeptide coprimycin. These are administered intravenously or by intramuscular injection. Also, we have the carbamazepines, imipramine, and cilastatin, and metformin. These beta-lactam carbamazepines are only given intravenously. This will end with the drug therapy of tuberculosis, and as I mentioned, you have to lay stress on first line drugs, the essential drugs, and to know all the details of these drugs. I hope that I could clarify this for you, and thank you for attendance.